So dear PTs, this is going to be one of the very important topics for our clinical practice. So these are the oldest and the most frequently used form of the medical imaging. This is the most commonly performed diagnostic X-ray examination. This is the chest X-ray. It makes images of the not only the lungs, heart, blood vessels, bones of the spine and the chest. Very common investigation, yet underdiagnosed or overdiagnosed. So these two are very common even today in our daily practice. Sometimes we are missing the diagnosis, sometimes we are overdiagnosed. So this is your common PA and the AP views. So if you see the AP and the PA views, in the AP view, the clavicles are at the above your apices of your lungs. And the heart appears to be enlarged in the AP view. Whereas in the PA view, so you can see the trachea, you can see the costophrenic angles, diaphragms, right heart of the border, left heart of the border, hyla, and etc. So for the erect PA, to diagnose any pathology of the heart or the lungs or the blood vessels, etc. Whereas the lateral view also we advise sometimes to localize the pathology. For example, the mediastinal masses, whether it is in the anterior mediastinal mass or the medial mediastinum or the posterior mediastinum or the left atrial enlargement or the right atrial enlargement, you need a lateral film. Supine film we often do in your emergency wards or in your ICU for all ill patients and those with the multiple injuries. Lateral decubitus view sometimes to note the small effusions. You are in a doubt whether it is a pleural effusion or a consolidation or etc. If you get a lateral decubitus view, that clearly shows you the some amount of the fluid, that is the decubitus pictures. Expiratory view, we rarely order expiratory view. Most of the views are the inspiratory views, but the expiratory view you get it in pneumothorax. So these are the basic points we are supposed to see in a chest X-ray. One stands for the trachea, whether it is a midline or deviating to the one side or pushed to the other side, and the right bronchus and the left main bronchus, etc. And the second point here is the hyla. Here with any lymphadenopathies or any vascular lesions here, the pulmonary arterial hypertension or sarcoidosis, etc. we can see at the hilar areas. Third point is the lungs. So in the upper zones or the mid zones and the lower zones, or any reticular densities or opacities or nodules, masses, all these things we can see in the lung lesions. Diaphragm. So the right diaphragm is at a higher level when compared to the left diaphragm, hemidiaphragm. And if the person is not noted the marker there, the left or the right side, the gas shadows will tell you. So stomach shadows or gas shadows will tell you that part of the diaphragm is on the left side. When the fellow is having the massive hepatomegaly, the right diaphragm of the diaphragm may be elevated. Or there may be sometimes eventuation of the diaphragm will be seen. And you have to see the fourth one is the diaphragm, yes. Fifth one is the heart. So here you can see the right border, left atrial enlargement, left atrial appendage, right atrium, etc. And most of the times in our clinical medicine, we not only concentrate on the lungs, we also concentrate on the heart, for the simple reason that if any cardiomegaly is there, is it the left ventricular cardiomegaly or the right ventricular cardiomegaly? When you are postulating the rheumatic RTCs, mostly is the mitral stenosis and the mitral regurgitation, then you can see the left atrial appendage to know whether the person is having a massive left atrial enlargement or the not. In pericardial effusions, we often see sometimes, maybe because of the coughs, extrapulmonary tuberculosis. So you can find the pericardial effusions, then you can see the bottle-shaped heart. And the sixth one is the aortic knuckle. In all the elderly individuals, you can see the calcification of the aortic root, and sometimes now you can see the aortic aneurysms, etc. And seventh is the ribs, and most of the times now they will have the rib fractures, or maybe the secondaries in the ribs, maybe because of the primary in the lungs, etc. So the ribs also you are supposed to note it. Scapula, very rarely we see the pathologies in the scapula except the some fractures or secondaries in the scapula. Spine is very, very important in the APU and the PA view. You can concentrate on the spine or the over penetrated film or under penetrated film, and that spine will help you a lot. Clavicles, so it's only to know whether the trachea is in the midline or the not, when the rotation of the X-ray is right or the not, so that you can tell you with your clavicle and the sternoclavicular junctions and the distance from your trachea. So all these things you are supposed to see in a chest PA view or in a chest AP view. Most of the time you concentrate on the heart and the lungs, but these are also very important. So to know all these things. So when you see a chest X-ray, please consider the A, B, C, D, E. A stands for airways, B stands for breathing, C stands for cardiac, D is the diaphragm, and E everything else. Everything else means your trachea, your ribs, your scapula, etc. See here, the costophrenic angle is very sharp. Suppose if the person gets the pleural effusion, so there will be the blunting of the costophrenic angles will be seen. Even in the blunting, not because of the pleural effusion always, maybe because of the mal-rotated X-ray also you can find the blunting of the costophrenic angles. So the film quality, Rife approach, so the rotation, inspiration, projection and exposure. So these are very, very important before you go into the conclusion of the film. Otherwise, if you don't give priority to these things, so definitely you think that the X-ray is going to be an abnormal X-ray. So this rotation, what do you mean by the rotation? Identify the medial ends of the clavicles and select one of the vertebral spinous process that falls between them. See here on the green part, green marking, you will have the spinous processes. And see the distance from the clavicle, sternoclavicular joint to this spinous process. So if the picture is good, if the film is good, that should be equidistant. It should not be deviated to the one side. The medial ends of the clavicle should be equidistant from the spinous process. Then the rotation is the normal one. If one clavicle is nearer than the other, I will show you some pictures later. Then the patient is rotated and the lung on that side will appear weight. A patient with a thoracic scoliosis may appear to have a rotated film, obviously, because of the skeletal abnormalities. Check whether the spinous process and the vertebral column are aligned. If they are, it is more likely that the patient is rotated. Here you can nicely noted that you see the spinous process, and which one is very closer, on the right clavicle or the left clavicle. So right clavicle is closer to the spinous process. That means the person is rotated towards the right. If the patient is rotated to their left, then the heart may appear the enlarged. If the patient is rotated to the right, then the heart size may be the underestimated. So this is also very important. See the cardiomegaly here, apparent cardiomegaly, because of this rotation. So cardiothoracic ratio here is the 53%. So same patient with no rotation of the film, here the cardiothoracic ratio is 47%. So the normal is less than the 50%. So this is very important. So from tomorrow onwards, you see this rotation of the film. So how is the spinous process? Is it the equidistant from your sternoclavicular joint or not? If there is rotated to the one side, which is closer to the one side, then the film is rotated and there will be the apparent cardiomegaly. See here, in abnormality here, looks like almost the normal. But consider the costophrenic angles on the left and the right. So left is very sharp, whereas the right is very sharp, and the left costophrenic angle is little bit blunted. So the reason for this here is again the rotation. See again the rotation. See the spinous process and the clavicle. It is so close and even the overlap on the right clavicle. So at first glance, the left costophrenic angle appears blunt. The patient is rotated, which results in the greater thickness of the breast tissues overlying the costophrenic angle on the left compared with the right. You may be misled to thinking there is a pleural effusion or other pathology causing the costophrenic angle blunting. So maybe the mild pleural effusion or maybe the pneumonitis, etc. So the rotation is very, very important to comment all these things. So to comment on the costophrenic angles and to comment on the cardiomegaly. Now inspiration. So RIFPF. To judge the degree of the inspiration, count the number of the ribs above the diaphragm. So this is very important, whether it is a good inspiratory fill or an expiratory fill. So here the ribs will help you. Counting the ribs will help you. So we count the ribs from the anterior and also from the posterior end. So the midpoint of the right hemidiaphragm should be between the 5th and the 7th ribs anteriorly. So if you count the ribs from the anteriorly, so the diaphragm, it should be on the either on the 5th or the 6th or the 7th ribs. If you count from the posterior end, it should be on the 10th rib. So if the more ribs are visible, the patient is hyperinflated. So let us see that 5th to 7th anterior and the 10th posterior. What do you mean by this inspiratory fill? See here. See, count from the anterior side and the second one. 1, 2, 3, 4, 5, 6. See the diaphragm. So the diaphragm at the midclavicular line. So it is at the 6th rib on the anterior side. So that is a good inspiratory fill between 5th to the 7th ribs. So count from the posterior ribs again. So maybe the posterior rib here, maybe the 9th or the 10th. So that is the normal. So if the heavy diaphragms lie at the level of the 6th anterior rib or the below, then the inspiration is adequate. If there are 8 or the 9 posterior ribs visible in the lung fields, this also indicates adequate inspiration. So remember 5th to 7th anterior ribs and the 10th posterior ribs. So this is the good fill, good inspiratory fill. Okay. See the film here. See what is the anterior rib count? 1, 2, 3, 3.5. Not even the 4th rib on the anterior is not visible. Okay. If few are visible, the patient has not managed a full intake of the breath, perhaps due to the pain or exhaustion of the disease. Is not a good inspiratory fill. So here you are thinking of some abnormalities here, maybe the cardiomegaly or maybe the lower lobe pathologies, etc. A poor inspiration will make the heart look larger, give the appearance of the basal shadowing, and cause the trachea to appear deviated to the right side. So first one is the rotation, I told you. So how to see the rotation, and the second one is the inspiration. So the mal-rotated, so there may be appearance to be some abnormalities. Again in the inspiration, the expiratory film also, then apparent cardiomegaly or some basal lesions. See the same picture. First one is expiration, the second one is inspiration. See the difference. See the difference. Okay. The first one, diaphragm is at the third one. Whereas in the second one, diaphragm is at 1, 2, 3, 4, 5, 6. Absolutely at the 6th level. Say here, Cori consolidation on the left lower lobe. First film, no consolidation in the second film. Okay. So the same patient in the expiratory film and inspiratory film. So we advise the radiographer to take the pictures very neatly. So concentrate on the rotation, not to rotate anything, and then concentrate on the inspiratory film, not on the expiratory film. Then the projection. Look to see if the film is AP or the posterior. Direction of the X-ray beam in relation to the patient. In the AP X-ray, the X-ray machine is in front of the patient and the X-ray film is at the back. That's what we do it in the ICUs. So the film is at the back of the patient and the machine is in front of the patient. That is the AP view. Whereas in the PA film, the beam is fired from the behind the patient and the film placed in front of it. So the standard X-ray is PA, but many emergency X-rays are the APs. These can be taken more easily with the patient in the bed, AP views. AP films are marked AP by the radiographer, but PA films are not often not marked since this is the standard projection. So if they didn't mark it, so it should be a PA view. Then we can also see, as a physician, we can judge whether it is an AP film or a PA film because of some differences, you know that. So this is the AP projection. So apparent heart size. In the PA projection, heart size is not enlarged. So that is the reason for the apparent cardiomegaly in the AP films. See the scapula. So these two are also at the equidistant, right scapula and the left scapula. Otherwise, there will be some differences in your cardiothoracic ratios. Then the exposure. Okay. To check the penetration, look at the lower part of the cardiac shadow. The vertebral body should only just be visible through the cardiac shadow at this point. So when you are seeing the heart and the right border and the left border, in that area, the vertebral body should only just be visible. So that is a good film. When you are not able to see the vertebral bodies totally, you are just visible. So that is a good film. If they are too clearly visible, then it is over penetrated. Okay, through the heart, you are able to see the spinous processes, vertebral bodies, etc. So that is over penetrated. If you cannot see them at all, then the film is under penetrated. So whether it is over penetrated, under penetrated, you concentrate on the vertebral bodies just behind the heart. If they are just seen, good penetration. All the ribs, all the vertebrae are well seen, it is over penetrated. Not at all seen, it is under penetrated. So these are the differences here. So the first one is the normal. See, they are just visible, the vertebral bodies. Under penetrated, you are not seeing anything here. In the over penetrated, you are seeing all the vertebral bodies there. So that is the differences between the under penetration and the over penetration. So again, this penetration is also very important. So before you go to the pathologies in the lungs, so the rotation is important, inspiratory film is very important, and then either whether AP or the PA, that is also important, and then the penetration is also important, and exposure. See the over penetration of the radiograph. All the thoracic vertebrae are visible through the heart shadow. Lung fields darker than the normal may obscure the subtle pathologies. You are not able to see anything except the very darkness in the lungs and inadequate lung details. Almost looks like your emphysema. So here, not only that, you please concentrate on the right paratracheal strip. See the line that. So the trachea on the right paratracheal strip. Then the aortic knob, pulmonary trunk, left atrial appendage. Here it is a concave. When the left atrial enlargement is there, then it will be the convex shape. So this is the para-aortic line. So follow the aorta, root of the aorta, and slowly go down. Then you can have a para-aortic line. Left ventricle, so that you can see that borders of the left ventricle. And the paraspinal line. Para-aortic line is different from the paraspinal line. So now you come to the right side. Then you will have the azygoesophageal recess, right atrium. So this border is the right atrium, then the left atrium there. Here the interlobar arteries. So as a good physician, so not only the heart and the lungs, you please concentrate on these points also, because these also will give you a clue towards a particular diseases. So the points here, the lines you are supposed to see are the paratracheal strip, aortic knob, pulmonary trunk area, left atrial appendage, para-aortic line, paraspinal line, of course left ventricle and the right atrium. Right heart border is formed mostly by the right atrium. And then azygoesophageal recess, interlobar artery. So don't forget all these things. These are very, very important for a physician point of view. So as I told you earlier, A for airways, B breathing, C cardiac, D diaphragm, E elsewhere. Here A is for airway. Look at the trachea, right and the left main stem bronchi and the intermediate bronchus. B is for breathing. Look to see if the lungs are uniformly expanded and compare the lung fields. Look around the edges of each lung to rule out any pleural effusions or pneumothorax or any pleural fibrosis or in the secondaries. Look at the 4 shell outs. Look for the cardiac size. Look at the great vessels, especially the pulmonary vessels and the aorta. So there will be the aortic aneurysms or pulmonary arterial hypertension, etc. Look at the mediastinum and the hyla. Those are very common lymphomas, sarcoidosis, etc. Or even the tuberculosis also. Look for a fracture. Here D not only for your diaphragm, here the disability. So they look for the fracture, especially of the ribs or the shoulder girdle. Everything else, air under the diaphragm is a surgical indication, the perforations. Look at the edges of the surgical emphysema. Look for the breast shadows. So a lot of the people know that after post mastectomy, so right breast mastectomy, left breast mastectomy. So then the changes will be there on the X-rays. Look for the foreign bodies and other unnatural presences. So all these things we are supposed to look up it in the X-rays. See airway. See the trachea. You have the right main bronchus and the left main bronchus. So that the junction is called as the carena. So this is the normal carena, that angle, right bronchus, left main bronchus, etc. And aortic knuckle just above that left main bronchus. So this is the normal pathology, normal physiology. But in pathology, the left main bronchus may be the much enlarged, maybe the left main bronchus may be left enlarged, or the carena, that angle may be expanded to maybe 90 degrees, and aortic knuckle abnormalities may be seen, and the trachea deviation to the one side or pushed to the other side. So all these things you are supposed to see in airways. See the first film, the second film, they have given the markers. So now see the first film. How is the trachea? Okay. See the right main bronchus. You appreciate the right main bronchus in the first film. You appreciate the left main bronchus in the first film. And see the aortic knuckle. Okay. So see the carena angle there. So that is how we have to see this airways. So not only the trachea, you are supposed to see the right main bronchus, left main bronchus, that carena, and also the aortic knuckle. So the tracheal deviation, very easily you can note it, and the carinal angle is also very important. Suppose if there is a mediastinal lymphadenopathies, so definitely the carinal angle will be widened. Abnormalities deviating the trachea away from the affected side, pneumothorax, effusion, large mass, they push it to the opposite side. Abnormalities deviating trachea towards the affected side, so mostly collapse of the lung, marked atelectasis, post-lobectomy, post-pneumonectomy, pleural fibrosis, pulmonary fibrosis. So these are the conditions where the trachea will be deviated to the same side. So mostly not only the collapse of lung, now post-COVID, so the pleural fibrosis and the pulmonary fibrosis. See there, now here you can appreciate the trachea deviation. Okay, so the high pressure in the left hemithorax, a massive left pleural effusion, maybe 2 liters, maybe 3 liters, maybe 4 liters, push to the structures to the opposite side. See the low pressure in the hemithorax, total collapse of the left lung. See the difference. In the first film, it is because of the effusion. How can you see it is a mass wave fusion? It is a heart border. See the heart border, right heart of the border. Okay, push it there. In the second film, it is the collapse. See the trachea. So trachea is on the left side in the second film. In the first film, the trachea is pushed to the right side. Okay. See the heart borders. In the first film, you are able to see the right heart border. In the second film, you are not able to see the heart borders here. So this is the very, very important. Now is carena. See the carena here, widened. In the second film, rightward deviation of the trachea due to the mediastinal mass. See the mediastinal mass there. Anterior mediastinal mass. Are you appreciating the mass? Near to the clavicle, sternoclavicular area. On the right side, you have the left side, you have the aortic knuckle. But on the same side, the right side, above that aortic knuckle area, you are seeing that mass area. That is your anterior mediastinal mass. Anterior mediastinal mass. So this you are supposed to see that. See in all the X-rays, no. So this is the mediastinal mass here. Okay. And concentrate on the carena. So this is the normal one. But see here, it is widened. Okay. See the heart. So is it heart or something else? So again a mass. Good, good. Okay. So this is a very important point. Then the B stands for the breathing. The basic rule is that black air, your lungs, and white, no air, mostly the heart, etc. Or the lungs uniformly expanded. Compare the lung fluids and look for the white areas, the shadows. Look around the edges of each lung, costophrenic angles, and 4 shell outs. See here, right heart border. So this is the right heart border. Okay. So the loss of the right heart border indicates a loss of the air in the middle lobe due to the collapse or the consolidation. So this is the big take-home point. So whenever you see the heart, you see whether the right heart border and the left heart border also. Suppose you are not able to see the right heart border clearly. So that shows some pathology in the middle lobe. It may be due to the collapse or the consolidation. So usually right middle lobe is a very small lobe. So any pathology in the right lobe you may not appreciate. Unlike your upper lobe pathology or the lower lobe pathology. So in the middle lobe pathology, you can appreciate indirectly through the right heart border. When you are not able to appreciate the right heart border fully, so definitely there is some abnormality in the right middle lobe. It could be a collapse or a consolidation. So here is about 6 feet distance from the machine to the chest. So the beam is minimally divergent. X-rays are parallel when they hit the thorax. See, I showed you now. So this is the right paratracheal strip. You can appreciate that white line. So this is the white line. This is the paratracheal strip. See the aortic knob. This is the aortic knob. Any pathology in this area, any aortic aneurysms, etc., you can appreciate. In the one field, you appreciate here is the anterior mediastinal mass. Okay. So this is the pulmonary trunk. You can appreciate in the chronic rheumatic heart diseases where there will be the pulmonary arterial hypertension and this will be very, very filled. So the left atrial appendage, I already show you left atrium enlargement. So instead of this concavity or the straight line, you will have the convexity. Convex border of the left heart border because of the massive enlargement of the left atrium. See, this is the aortic line. See the aorta, you come here. So this is the aorta. So by this is the aortic line. So this is the paraspinal line. So this is the spine. These are the vertebrae and this is the paraspinal line. Of course, the left ventricle mostly formed by the this is the interlobar artery. This is the right atrium. So the other findings. So normal junctional lines. These normal mediastinal lines are not visible in all normal chest X-rays. Knowing what they represent can help avoid the confusion. The junctional lines are the point of contact of the left and the right lungs. The right paratracheal line is the edge of the trachea contrasted against the air in the trachea and the adjacent right lung. So this is the right tracheal line. The azygoesophageal line, so this one, marks the medial edge of the azygoesophageal recess, the point of contact between the medial edge of the right lung and the soft tissue structures of the mediastinum, mostly the esophagus and the azygosphincter. Widening of the paratracheal line more than 2 to 3 mm may be due to lymphadenopathy, pleural thickening, hemorrhage, fluid overload, and heart failure. So we are interested in most of these conditions. Mostly the lymphadenopathy, thickenings, fluid overload, and the heart failure. So all these can be concentrated on the paratracheal lines. So from tomorrow onwards, whenever you see an X-ray, so not only the trachea, so concentrate on the paratracheal lines also. Displacement of the para-aortic line. It can be due to the elongation of the aorta, maybe aortic aneurysm, dissection of the aorta, and rupture of the aorta. So this is the aortic line, para-aortic line. This is a very, very important. So the para-aortic line. Okay, you should get an X-ray of the Rajinikanth. You can identify the abnormality in the para-aortic lines. So that aortic aneurysms, dissection of the aortic aneurysm, etc. So you can see the abnormalities in this para-aortic line in these conditions. Paraspinal line. I told you the paraspinal line. So this is the paraspinal line. So this may be displaced by a paravertebral abscess, hemorrhage due to a fracture, or extravertebral extension of a neoplasms. So the mostly we see the paravertebral abscesses there. So these also can be seen by the paraspinal line. So not only our the lungs and the heart, so concentrate in the trachea, concentrate in the carina, concentrate the paratracheal lines, aortic line, para-aortic lines, aortic knobs, and then the paraspinal lines also. Azygoesophageal recess is the region inferior to the level of the azygous vein, arch in which the right lung forms an interface with the mediastinum between the heart anteriorly and the vertebral column posteriorly. The border on the left side of the esophagus. Deviation, hiatus hernias, esophageal disease, left atrial enlargement, subcarinal lymphadenopathy, and bronchogenic cysts. See, nowadays we are seeing a lot of the GERDs, hiatus hernias. So if the patient's history is more of the GERD, and if you take an X-ray, so you have to concentrate on the azygoesophageal recess. Because deviation of this line is caused by hiatus hernias. Where is that line? So this is this azygoesophageal recess. See the deviation of the azygoesophageal line on the PA film. So here is the deviation. This deviation is caused by hiatus hernia. So advise them barium swallow. So hiatus hernia. So the arrow point to the barium contrast within the hiatus hernias. So vena azygous lobe, a common normal variant is the azygous lobe. So these are the azygous lobes. So this is very, very rare. See in some patients, an extra joint is seen in the anterior part of the first rib at the point where the bone meets the calcified cartilaginous part. So this is an extra bone. This may simulate a lung mass. So this is a very, very important. Whether it is a mass or extra bone. Okay. So pectus excavatum, etc. So these are all the structural lesions or the bony lesions. The right heart border can be ill-defined, but this is the normal here. It produces a shell-out sign, simulating a consolidation or atelectasis in the right middle lobe. See here, I told you no, right heart border, you are not able to see clearly. So reason is right mid lobe lesions, could be consolidation or the collapse. Okay, so it produces a shell-out sign, thus simulating consolidation or atelectasis of the right middle lobe. The lateral view is helpful in such cases. So when you're in a doubt, so get in a lateral view. It's a congenital deformity of the ribs and the sternum, producing a concave appearance of the anterior chest wall. So these are the lateral views. So sometimes you have to order the lateral views, especially when you are thinking of your hilar adenopathies or mediastinal masses or left atrial enlargement or right atrial enlargements, etc. So these will definitely give you. See the border of the left atrium. This is the border of the left atrium, border of the left ventricle, and this is the IVC area in the lateral field. So the left atrium, left ventricle, and IVC. Lungs become more radiolucent here. So this is the left atrium, and this is the left ventricle, and this is the IVC. On a normal lateral view, the contours of the heart are visible and the IVC is seen entering the right atrium. Retrosternal space contains the air and should be radiolucent down to the level where the right ventricle borders the sternum. Small back is, so this is the radiolucent areas. Any radio-opacity in the upper retrosternal area is suspected of a process in the anterior mediastinum or upper lobes of the lungs. Any pathology here in the upper lobe pathologies. As you go from the superior to the inferior over the vertebral bodies, they should get darker because usually there will be less soft tissue and more radiolucent lung tissues. So there are zones in the lungs. Upper zone represents up to the second intercostal space approximately. Middle zone from the second to the fifth, and the lower zone from the fifth intercostal space to here the abnormalities, increased density or the decreased density. Lung abnormalities with an increased density, also called as opacities. They are the most common. Decreased density, lucency, a practical approach is to divide these into 4 patterns. A consolidation or interstitials or nodules or the masses. So this is the opacities. So increased densities, more of the white in a background of the black. Any pathological process that fills the alveoli with the fluid, pus, blood, cells, including the tumor cells, or other substances resulting in the lobar, diffuse or multifocal ill-defined opacities. So depending on the size of these opacities, you can consider them as the full consolidation or total lung or partial lung, etc. Interstitial, involvement of the supporting tissue of the lung parenchyma resulting in the fine or the coarse reticular opacity of the small nodules. So we discussed about this interstitial involvement when we dealt with the ILD, interstitial lung disease. Nodules are the mass. Nowadays we are seeing a lot of the oncology cases. So the bronchogenic carcinoma lung has increased in its incidence. So we see a lot of the nodules in the secondaries. So any space occupying lesion, either solitary or the multiple. Atelectasis is the collapse of a part of the lung due to the decrease in the amount of the air in the alveoli, resulting in the volume loss and the increased density. See here. So they have given all the 5 points here. First one is the consolidation. So this is the consolidation. See, this is the interstitial diseases. And this is the nodule. So this is the mass. And this is the atelectasis. Okay. So all these things you are supposed to see in the lungs pathology whenever you see an X-ray. So not be happy with only consolidation alone. So concentrate on the interstitial part, whether there are nodules are there, whether there are masses are there, or any atelectasis or the collapse. Consolidation, the classical finding, the Charlotte sign, that is the loss of the lung at the soft tissue interface. Air bronchogram, extension to the pleura or the fissure but not crossing it, no volume loss. It's an ill-defined homogeneous opacity obscuring the vessels. It is not a heterogeneous opacity, consolidation. Ill-defined homogeneous opacity. See, lung abnormalities mostly present as areas of increased density. So these are the consolidation, atelectasis, nodules, etc. And decreased density in the two things. One is the emphysema or the cysts. So the consolidation pattern is the diffuse, lobar, multiple ill-defined, batwing, reversed batwing. So the diffuse, you can see the pulmonary edema, the bronchopneumonias, hemorrhages, lymphomas, etc. Lobar, in the lobar pneumonias or hemorrhage, lymphomas or sarcoidosis. Multiple ill-defined, bronchopneumonias, embolization, lymphomas, metastasis. Batwing, pulmonary edema is very common to see. Bacterial pneumonias, PCP, viral pneumonias. Reversed batwing, bronchoalveolar carcinoma, BOOP, eosinophilic pneumonias, and sarcoidosis. You can narrow down the DD, depends on the pattern and the clinical presentations. So whenever you see the consolidation, so you think all these things. When it's a diffuse consolidation, the DD is this. When you have the batwing consolidation, the DDs are pulmonary edema, the bacterial pneumonia or viral pneumonias. When it's multiple and ill-defined, it could be bronchopneumonia or the metastasis or embolizations. See HIV patient, fever and cough. Okay. See, where is the pathology? Is it in upper lobes or the mid lobes or the lower lobes? Mostly the mid lobes and the lower lobe pathology. See the hila on the right side, a little bit enlarged, right hila. Okay, so these are the pathologies. These are the pathologies. See the costophrenic angle is free here. This is also free here. Diaphragm is good. Diaphragm is good. Clavicle, the trachea midline. So equidistant, no rotation. So anterior 1, 2, 3, 4, 5, 6, good. Posterior 1, 2, 3, 4, 5, 6, 7, 8 or 9 are the 10. So this is the border. This is aorta, aortic nickel. So the paratracheal lines, aorta. This is the para-aortic line. So this is the paraspinal lines. So you are not able to see the vertebrae here, just visible. It's a good penetration. Not totally visible. So this is under penetration. When it is, overexposed, then it is over penetration. See the acute dyspnea. Okay, the same patient. See here. So cardiomegaly. Okay, so could be ARDS or pulmonary edema, acute pulmonary edema. Here, pathology is here. Okay, so this is the lobar consolidation, a lobar pneumonias, a streptococcal, Klebsiella, etc. Neoplasms, hemorrhage or organizing pneumonia, eosinophilic pneumonia, sarcoidosis. So these things you should think of it. See the confuse. This is the diffuse consolidation. Not only on the right lung, but also on the left lung. See the difference here. So this is the only upper lobes. No mid lobe, no lower lobe, but exclusive in the upper lobes. Here it is the diffuse one. So the pathology is different. Organisms are different here. In the diffuse edema, maybe heart failure, volume overload, ARDS, hypoalbuminemia, acute kidney injury or acute under CKD, transfusion reactions, bronchopneumonias of different pathologies, hemorrhages, especially in the autoimmune diseases, lupus. So these are the things. See the pathology here. See here. Some infiltrates. Here atelectasis. See the diffuse cardiomegaly. So maybe a rheumatic heart disease. Both left atrium, left ventricle, right atrium, etc. See here. Interlobar effusion. Interlobar effusion here. See a mass. Right upper lobe mass. Here a small nodule. So see the difference between the mass and the nodule here. Okay. See here the pneumatic patch. Here, this is the pneumothorax. Okay. So these are different pathologies. So whenever you see an X-ray, you have to think all these things. So don't be hurry in reading a chest X-ray. Take your own time, but don't miss any abnormality in that particular X-ray. See the difference between the bacterial pneumonia and the viral pneumonias. See, in the bacterial pneumonia, mostly it is a lobar pneumonias, unless it is a bronchopneumonia. Okay, so here the right lobe is involved. Right mid lobe is okay, lower lobe is okay, left lobe is not a good film, so I'm not able to appreciate on the left side lung. It's an AP view. It's an AP view. Okay. See here, viral pneumonia. So some abnormals in the upper lobe, some abnormals in the mid lobe, here the lower lobe, etc. So this is a diffuse one is mostly the viral pneumonias. See what is the pathology here. Is it the left lung or the right lung? Right lung. Okay. Where is the pathology? Is it the upper lobes or the mid lobe or lower lobe? This is the lower lobe. Is there any air bronchogram is there? Yes. So this is the air bronchogram. It is a fuse pathology. So your diagnosis, is it pleural effusion or tuberculosis or pneumothorax or pneumonia? So pneumonia is the right answer. Suppose pleural effusion. So what points you, where you are supposed to see the pleural effusion? Yes, this is sharp. Here the costophrenic angles are the sharp. Okay. And about the tuberculosis, mostly the upper lobe pathologies. Of course, lower lobes also common in elderly individuals, alcoholics, diabetics, and HIV individuals, HIV positive or AIDS. In these four conditions, even the lower lobe tuberculosis is also common. Mostly it is bilateral. Pneumothorax, you can have a absence of the lung fields and you can have a line there. So this is how we have to differentiate it. So it's a simple case in pneumonias. Very often you see as a physician, you should not miss this diagnosis. See the different pneumonias here. See the lobar consolidation. This is the upper lobe lobar. See the diffuse consolidation. So both. Here the multifocal, ill-defined. This one. Atelectasis. So the right lobe. Fine reticular interstitial, mostly the lower zones. I have shown you the one picture. Interstitial, this is the area where you are supposed to see here. Coarse reticular, this is the fine reticular, this is the coarse reticular pattern. See the different nodules, the fine nodules, small nodules. Masses are much bigger. See the single nodule. This is the solitary pulmonary nodule. See the masses. See the size of the mass here. See the mass here. See the mass. See the mass here. So these are the multiple masses. Maybe the secondaries in the lung. So this is secondaries in the lung. A simple pulmonary, solitary pulmonary nodule. This is the fine nodulars, multiple nodules, coarse reticular pattern, fine reticular pattern, atelectasis of the right lobes. Here the ill-defined multifocal, a diffuse one. This is the lobar consolidation. Reticular pattern, fine nodular, and the cystic diseases are the different subsets in your interstitial diseases. The reticular pattern edema, heart failure, fluid overload, interstitial pneumonias, viral, mycoplasma, lymphangitis carcinoma, honeycombing in autoimmune diseases like rheumatoid arthritis, systemic sclerosis, etc., dermatomyositis. Some drugs, maybe amiodarone, nitrofurantoin, especially the methotrexate lung, we consider it as a methotrexate lung. So methotrexate is the most favorable drug to prescribe in the rheumatoid arthritis. Drug of choice of rheumatoid arthritis nowadays is the methotrexate. You have to start from the day one. Not only the single agent, maybe the 2 or the 3 DMRDs. So now the present concept is actually combination of drug therapy, like your hypertension, the diabetes, even in the rheumatoid arthritis also, the combination DMRDs, either methotrexate plus hydroxychloroquine or methotrexate plus leflunomide or methotrexate plus rituximab or adalimumab, etc. So that is a combination drug, because you should know everything about the rheumatoid arthritis. It's a very common disease in our areas. Cystic disease, So these are all the histiocytosis, etc., pneumatocytes, or lymphocytic interstitial pneumonias, fine nodules in sarcoidosis, metastasis, and tuberculosis, especially the tuberculosis, that is miliary tuberculosis. So fine nodular interstitial patterns. See here the reticular, the pulmonary edema, reticular nodular, some sarcoidosis or tuberculosis, reticular high attenuation, your pulmonary edema, reticular low attenuation, emphysema, cystic diseases. So there are the different interstitial patterns. So this is most of miliary tuberculosis. See the fine nodular bilateral. Okay. Atelectasis or lung collapse is a result of the loss of the air in the lung or part of the lung with a subsequent volume loss due to airway obstruction or compression of the lung by the pleural fluid of the pneumothorax. The key findings in atelectasis are sharply defined opacity, obscuring the vessels without the air bronchogram. So the air bronchogram is a feature in your consolidation, whereas in atelectasis you don't find any air bronchograms. There will be the volume loss, whereas in pneumonias you don't have any volume loss, but in atelectasis you will have the volume loss, resulting in the displacement of the diaphragm or the fissures or hilum or the mediastinum. So these will be displaced when there is an upper lobe atelectasis. So there is some displacements in your trachea, etc. Or in the lower lobe collapse, so there will be some displacements in your diaphragms. In the mid lobe collapse, so there will be some displacements of your right heart of the border. So these are the very, very important. Resorption and the relaxation. Resorption in the mucus plug is a very common nowadays. Tumors, foreign bodies. Relaxation, pleural effusion, pneumothorax, and rounded atelectasis. Plate-like atelectasis. These are characterized by the linear shadows of the increased density at the lung bases. See the lung bases. See this line. Are you appreciating this line? See this line. Okay. These are usually horizontal, measure 1 to 3 mm in thickness, and are only few centimeters long. In most cases, these findings have no clinical significance and are seen in the smokers and the elderly individuals. So these lines we often see in the smokers and in the elderly individuals. They are seen in patients that are in the poor condition and who breathe superficially, for instance after the abdominal surgery. See an abnormality here? Lungs, the right side? No. But on the left side, appreciate this one. Okay. Is this a nodule or a mass? It is a mass, not a nodule. Okay. Solitary mass. So the multiple masses, metastasis, or some infections, or some inflammations, some vascular, some inhalations, etc. See the multiple masses here. So this is the one mass. This is one. This is a one. This is one. This is one. Here. Here. So this is that multiple here. See here also. See multiple masses. Decreased density of the lucencies. A more practical approach is to describe the areas of decreased density in the lungs. A cavity lucency with a thick wall, a cyst lucency with a thin wall. So this is the difference between your cavity and the cyst. So the cavity will have a thick wall and cyst will have a thin wall. Emphysema without a wall. Okay, so all these three you can have a decreased density or the lucencies. So the increased density, more of consolidation, some masses, some atelectasis, okay, or some miliary tuberculosis or sarcoidosis, etc. But here the decreased density, it could be a cavity or could be a cyst or an emphysema. So these two will have the walls. Without the wall is the emphysema, thin wall in cyst and thick wall in the cavity. See here the picture. So this is the cavity. So these are all the big cavities. See the wall of the cavities. See the cysts, very thin walls. Very thin walls. Here the very thick wall. Here the very thin wall. This is the difference between the cyst and the cavities. And emphysema, you are not finding any wall here. So this is emphysema. In all these things, there is a decreased lucency. Emphysema, common feature seen on the chest X-rays, hyperinflation with the flattening of the diaphragms. So elongated lungs, tubular heart. These two are very common in our emphysema picture. So hyperinflation with the flattening of the diaphragms, increased retrosternal space, bullae, and enlargement of the pulmonary artery or the right ventricle. So that is carpulmonale. See the here. See the diaphragms. Usually you expect a concave diaphragms. Okay, so this is the diaphragms are usually like this in rotation of our X-rays. But here there is a flattening of the diaphragms. This is because of the elongation of the lung fields. And again in the heart also you can have a tubular heart. Okay. Shell out sign. The loss of the lung or the soft tissue interface due to the presence of the fluid in the normally air-filled lung. So that is the sign. So reason here is the presence of the fluid in the normally air-filled lung. If an intrathoracic opacity is in anatomic contact with the border, then the opacity will obscure that border. Commonly seen with the borders of the heart, your right heart and the left heart, aorta, chest wall, and the diaphragm. Mostly we see with the heart and we see with the diaphragm. At the costophrenic angles or at the cardiophrenic angles. See here. See here. Okay. So which pathology here? Right midlobe pathology. Are you able to see the right border here? So it is obscuring the right border here. This is a shell out sign. You are appreciating the left border, not the right border. See, this is the finger in glove. See the one lesion here, one lesion here. Okay. See the trachea, deviated to the right side. So this is the aorta, aortic line, the paraspinal line, both are the same. Here the impacted bronchi appear radiographically as opacities, the distinctive opacities. Allergic bronchopulmonary aspergillosis. See the bulging fissure sign. Okay. Consolidation spreading rapidly, causing lobar expansion and bulging of the adjacent fissure inferiorly. So this is the fissure. So this is the fissure. Okay. So this is the upper lobe. Maybe the mid lobe also. Okay. So this is the lateral film. Lateral film. Consolidation spreading rapidly. So mostly Klebsiella pneumoniae involving the right upper lobe. Golden X. When a lobe collapses around a large central mass, the peripheral lung collapses and the central portion of the lung is prevented from collapsing by the presence of a mass. So that is the golden S. The relevant fissure is concave towards the lung peripherally but convex centrally. See here. The fissure resembles an S or a reverse S. Pleural abnormalities. The pleura and the pleural spaces are only visible when they are abnormal. There should be no visible space between the visceral and the parietal pleura. Check for the pleural thickening and the pleural effusions. So usually they are not visible normally. When they are abnormal, they are visible. Effusion will cause blunting on the lateral costophrenic sulcus large enough on the posterior costophrenic sulcus. 200 ml of the fluid are needed to detect an effusion in a PA film. So 200 ml is required to appreciate in the PA film. Will approximately 75 ml of the fluid would be visible in the lateral view. So when you are less than the 200 ml, it is not possible in your PA view. So still your doubt is there for the pleural effusion, get a lateral view. Even a 75 ml also can be detected in the lateral film. In the AP film, the effusion will appear as a graded haze that is denser at the base A lateral decubitus film is helpful in confirming an effusion as the fluid will collect on the dependent side. See here. So this is the effusion, shifting the heart to the left side, and this is the concave upper border. Okay, the left lower zone is uniformly weight here. At the top of this weight area, there is a concave surface. So this is the meniscus sign. So don't expect the convexity here, the pleural effusion. The concave upper border. The left heart border, costophrenic angle, and the hemidiaphragm are obscured. Slight blunting of the right costophrenic angle indicates a small pleural effusion on that side also here. Okay. See the lateral decubitus film. So even a 75 ml is sufficient to cause an abnormality here. So this is the lateral decubitus film showing the effusion. This is the PA view. More than 200 ml is required here. Maybe it may be 1 to 1.5 liter to this extent. See the 200 to 300 ml. Just there will be the blunting of the costophrenic angle here. When it is the 2 liters in the lung, when there is 5 liters, so this is that one. So it takes about 200 to 300 ml of fluid before it becomes visible on the chest X-ray. 5 liters of the fluid is present when there is a total opacification of the hemithorax. Earlier I have shown you 2 pictures. One is the trachea deviated to the opposite, another one trachea is deviated to the same side because of the collapse of the lung. So that thing, total hemithorax is totally the pleural effusion. So it should be more than 5 liters. See the pleural fluid here. So no costophrenic angle, no cardiophrenic angle, right port is not seen. So total opacification, no lung tissue is not at all seen here. Okay, so this is pleural effusion. What could be the cause for this pleural effusion? Is it tuberculosis? Could be malignancy. So what are the points to say it is a malignancy? See the here. Okay, these two are the big masses. Okay, so this could be malignant pleural effusion. Malignant pleural effusion. Okay. See the subpulmonic effusions. Subpulmonic effusions. Right subpulmonic effusion here. See the diaphragm. So the left diaphragm, here the right diaphragm is very high, to very high level. This is the right subpulmonic effusion and the left subpulmonic effusion. Free flowing versus the loculated pleural effusion. See, this is the, I told you now, convex concavity upwards. So this is the left pleural effusion here. Typical left pleural effusion. Maybe about 600 ml to 800 ml, etc. See here, this is the loculated effusion. You are not able to see the lung tissue at all. So this is the border of the pleura. So this is the loculated pleural effusion. So this is the diffuse pleural thickening. See the pleural carcinomatosis. This is the pleural carcinomatosis. And this is the pleural tuberculosis. So I am not able to appreciate. I don't know what is the difference between these two. But definitely the history will tell you something about whether it is the tuberculosis or the carcinoma. See the pleural plaques. Okay. Pleural plaques, asbestos exposure. So pneumoconiosis. See, these are all the pleural plaques. So those people who are working in the mines, asbestos mines. So the typical X-ray is like this will be. So these are all because of the pleural plaques. See, in this also you can appreciate. This is the pleural plaque. Okay, here also you can appreciate. So these are. Here, these are the pleural plaques. See the reverses, goldenness, reverses, etc. So these are the pleural opacities. See the pleural opacities. Right lung is okay. The left side, you can appreciate these things. Unilateral pleural calcifications. These are due to Cox emphysema, or hemorrhage. Pneumothorax appears in the chest X-ray as air without any lung markings. PA film, it is usually seen in the apices since the air rises to the least dependent part of the chest. So when there is very mild pneumothorax, it will be seen in the apices. Air rises to the least dependent part of the chest. Air is typically found peripheral to the white line of the visceral pleura, best demonstrated by an expiratory film, not the inspiratory film. So inspiratory film, most of our pictures will be seen. In expiratory film, to rule out the pneumothorax. So this is a deep sulcus sign. This sign refers to a deep collection of the intrapleural air. This is a pneumothorax. In the costophrenic sulcus, as seen in the supine chest X-rays. See here, this line. So this is the pleura. So this is all the pneumothorax. No lung tissue at all. This is the border of the pleura here. Here you can appreciate pneumopericardium. See the strip here. So this is the pneumopericardium. So what is the organism? Gas producing organisms. Okay. So that you think of this. This is the fallen lung syndrome. This sign refers to the appearance of a collapsed lung occurring with a fractured bronchus. So fractured bronchus. Collapsed lung. The bronchial fracture results in the lung to fall away from the hilum, either inferiorly. So this is the hilum area. This is the inferior area and this is the lateral. In an upright patient or posteriorly as seen in the CT in a supine patient. Pneumothorax causes a lung to collapse inward toward the hilum. Spontaneous pneumothorax, subpleural bleps rupture, lung diseases, maybe COPD. Recognition of a pneumothorax depends on the volume of the air in the pleural space and the position of the body. See the pneumothorax here. It's the typical pneumothorax. See the here border. Okay. No lung tissue at all. No aeration at all. So this is the massive pneumothorax. And again the heart is pushed to the opposite side. Like your pleural effusion. Here the mediastinal structures are all pushed to the opposite side. So this is the pneumothorax. So even a first year postgraduate should identify this pneumothorax, massive pneumothorax. See here, where is the pneumothorax? Here you are able to see the lung markings. You are able to see the lung markings, all these areas. Where you are not able to see this area. This area. See the beautiful marking here. So this is the pleura. So this area is the pneumothorax area. Okay. Right upper lobe collapse. Shift of the fissures, crowding of the vessels and the airways, increased opacity. Here, appreciate the upper lobe here. See, there is a density here. So this is the upper lobe collapse. Okay. See the lower lobe collapse. Posteromedial and inferiorly. Common for triangular opacity behind the heart. See, this is all the heart. And again, there is a triangular opacity behind the heart. Inferior displacement of the left hilum. See the left hilum. Obscuring of the outline of the descending aorta. See the descending aorta. Okay. So this is the lower lobe collapse. Now the hidden areas. In the apices, usually you don't find the total area of the apices unless we ask the fellow to get the apical view, diaphragms, retrocardiac region, area adjacent to the chest wall, mediastinum, ila, and the bones. So as a good physician, you have to concentrate on these areas also, hidden areas. Apices, diaphragm, retrocardiac region, area adjacent to the chest wall, mediastinum, hilum, and finally bones. That includes your ribs, clavicle, and scapula. See, hilum is a wedge-shaped area on the central portion of the each lung. It consists of vessels, bronchi, and the lymph nodes. 97% of the left hilum is higher than the right. So that is the most important point. Right hilum and the left hilum. Which one is at higher side? So the left hilum is at higher than the right side in most of the times. So 3% they are at the same level, right hilum and the left hilum. Should be clearly defined with the concave lateral borders. Hilar enlargement. So the malignancy, some infection causes and some others. Malignancies, lung cancer, lymphomas, metastasis, etc. Infections, tuberculosis or virus, histoplasmosis. In others, most important the sarcoidosis and the silicosis, pulmonary hypertension, pulmonary artery aneurysms and the bronchogenic cysts. So most of the things I often see as a physician, you see a lot of the sarcoidosis, pulmonary hypertensions, tuberculosis, virus, fungal, and of course malignancies like lung cancers and lymphomas. See here. So this is the left hilum. This is the right hilum. Which one is at higher side? Left hilum is at higher. See the difference here. Hilar enlargement. When compared to the left and right, here the left hilum is much enlarged when compared to the right hilum. Here, right hilar enlargement. So this right hilum is much enlarged than the left hilum. It is almost like the equidistance. 97% it is at upper level, 3% at the same level. Okay. So what are the causes for these hilar enlargements? It could be infections, malignancies and others. Malignancies, your bronchogenic carcinoma, lymphomas are secondaries. Infections, whether tuberculosis or histoplasmosis, some viral. Others, most important is sarcoidosis, silicosis, pulmonary arterial hypertension, etc. Is it because of the pulmonary arterial hypertension? These cases? No. Pulmonary arterial hypertension, you expect right heart failure. Okay. So the right heart border. Here, right heart border is the normal. Even in here also it's a normal. Not of much cardiomegaly here. So probably it's not of the vascular. It could be either infections or the malignancies. Mostly it is not malignant, I think. So it could be infections only. So what infections? Maybe tuberculous lymphadenopathies or some viral or maybe some sarcoidosis. Okay. So same picture here also. Most likely looks like a sarcoidosis here. So here the biopsy is very important. So ultrasonic biopsy or CT guided biopsy will clinch the diagnosis. Otherwise, you give a short course of steroids and everything will be disappeared, provided if it is a sarcoidosis. Okay. So meanwhile, when you are doubt in tuberculosis, get the Mantoux or quantiferon gold, etc. Okay. That's how we have to deal the different etiologies of these hilar adenopathies. See, as I told you, lateral X-ray will help you in any hilar adenopathies and also in the mediastinal adenopathies. See the mediastinal masses here. See anterior, middle and the posterior. See the anterior. So this part is the anterior in your lateral view. So this part is the anterior. This is the anterior. This is the superior. So middle lobe. This is the middle lobe, middle mediastinum, and this is the posterior mediastinum. So what are the causes for the anterior mediastinal lymphadenopathy? So there will be the lymphomas, thyroid, thymus. These two you should remember in the anterior mediastinum. Thyroid, thymus, lymphomas. And the middle mediastinum, again the lymphadenopathy, aortic aneurysms and hernias, hiatus hernia, dilated esophagus, etc. Posterior mediastinum, mostly neurogenic tumors or some sarcomas, etc. Okay. So by lateral field, you can appreciate the mediastinal masses. So in the lateral field, you should think that this is the anterior, this is the superior, middle mediastinum and the posterior mediastinum. Close to your spine is the posterior mediastinum. Close to your sternum is your anterior mediastinum. And between the anterior and the posterior, this is the middle mediastinum. So middle mediastinum occupies about 60 to 70% of the space here. Maybe 10 to 20% anterior mediastinum. Maybe 15 to 20% posterior mediastinum. So as a physician, sometimes you have to alter the lateral chest X-ray also. So that clinches you, whether you are in doubt whether it is an anterior mass or a middle mass or the lower mass, because the DDs will be different. Mostly posterior mediastinum not our medical cases. Mostly the sarcomas, neurogenic tumors, etc. So the middle mediastinum and anterior mediastinum we are interested because these are because of the lymphomas and maybe the thyroid or the thymus or aortics. See the hilar enlargement. Here the pulmonary hypertension. So the cause is here is the pulmonary hypertension. See the heart. Right heart border. See the left heart border. See the hilum here. So this is the pulmonary artery. Pulmonary arterial hypertension. Okay. Hilar enlargement. See the anterior. See the posterior. Normal. See the middle mediastinum. Mostly the middle mediastinum. See here. Left hilum, right hilum. Which one is abnormal here? Right hilum is abnormal. Left hilum is the okay. Which one is at higher side? Left hilum is at higher side. Okay. So this is the abnormal here. So some mass is also here. Round mass. Maybe 3 to 5 centimeters. So that is the possible tumor here. So this is the enlarged hilum. So this tumor, this is enlarged node maybe. So this is the lobes. Nodal hilar adenopathy. Secondary to this tumor. So lung cancer with the hilar node metastasis. See, lot of the knowledge we will get it while see the X-rays. So don't think that X-ray means only lungs, tuberculosis, etc. So in end, lot of the findings will get it from the chest X-rays. See the vascularity here. See if you see the hilum. So this is the left hilum. This is the right hilum. Which one is abnormal? Right or left? Both are abnormal. Both are abnormal. That's the right answer. Since the right hilum is abnormal, left hilum is abnormal. Is it nodal or vascular? Is it tuberculosis or is it sarcoidosis or is it pulmonary arterial hypertension, etc.? So you are not in a doubt. So get the lateral film. Get the lateral film. So in the lateral film, what you are seeing? Good. So these are all the different nodes. So it is not vascular, but it is lymph node. See how nicely you can differentiate. Okay. So in a chest X-ray, we should look for the 360 degrees. So don't be hurry in your diagnosis. One thing is very clear here. Upper lobes are the normal, mid lobes are the normal, lower lobes are the normal, costophrenic angles are the normal, cardiophrenic angles are the normal, heart border not much enlarged in the heart. Okay. Aorta is okay. The clavicles are okay. The trachea is in the midline. Okay. So the only pathology here is the hilar adenopathies. So what could be the reason for this hilar adenopathy? Both are dilated. So what could be the reason? Just don't send it for the CT scan or to the pulmonologist or anything else. Just get the lateral X-ray. So in the lateral X-ray, you see lateral X-ray close to the spinal is posterior mediastinum. This is the anterior mediastinum. This is the middle mediastinum. See the beautiful nodes here. 1, 2, 3, 4, 5, maybe the 6, maybe the 7. So these are all the different nodes. Suppose it is a vascular. It's a uniform enlargement vessels. Whether the pulmonary artery, uniform enlargement, with aorta, uniform enlargement. So very easily you can do. So here your diagnosis lymphadenopathy. Then what could be the cause? Only 2 or 3 reasons. It could be tuberculosis or it could be sarcoidosis. So get the FNAC done or a biopsy done. So that can be done by our interventional radiologist or our radiology friend. That is the reason why I always tell you that don't underestimate our laboratory medicine personnel. Whether a biochemistry or a pathology or microbiology or radiology, they are the most useful persons for all of our growth. So without their help, you will not flourish in your profession. Okay. So don't think that physician is so great. Those people are also so great because of their understanding of the pathology, because of their molecular diagnostics, because of their interest in this diagnosis methods. So definitely they guide us a lot. And finally, you can give some prescription and the people will be very happy. The seen hero is you, but unseen heroes is those people, laboratory medicine people. Okay. See the heart here, heart size. So you all know that cardiothoracic ratio. You see the thorax ratio and then see the cardiac ratio here. So cardiac size is assessed as the cardiothoracic ratio. CTR is the transverse cardiac diameter divided by the transverse chest diameter. So normal approximately 50%. In the neonates it is 65%. We are not interested in the neonatology or the pediatrics, but for adult practice not more than 50%. See the mediastinum here. See where abnormality. So this is the abnormality. So do you find this abnormality? So get immediately lateral view. See the lateral view. The anterior mediastinum or the posterior mediastinum here. Mostly the anterior and the middle mediastinum. So this is the middle mediastinum. See the picture here. So shadow in shadow. Okay. So this is the right heart border. And you are seeing another picture here. Okay. This is another picture here. So that is the reason retrocardiac areas also you have to concentrate it. Retrocardiac areas also you have to concentrate. See which one is brighter here. The front one or this one or this one. Which one is brighter? So this one is brighter. So that means this is behind the heart. Am I clear? Okay. So this is the retrocardiac area. Retrocardiac area. So which mediastinum it comes? Anterior mediastinum or middle mediastinum, posterior mediastinum? Excellent answer. Excellent answer. This is the posterior mediastinum. See the left lateral. So very close to the sternum. Which one? Posterior. So the diagnosis clinched. It could be some sarcoma, some neurogenic tumor, etc. So then refer to a particular surgeon for the replacement. So don't be hurry. So this is the beautiful picture saying that picture in the picture. The more brighter one is the right heart. So it should be behind the heart. It is in the posterior mediastinum. Immediately get the lateral view. So this is the anterior mediastinum. This is the middle mediastinum. And very close to the spine is the posterior mediastinum. See the picture here. Round picture with the beautiful borders. Clear cut border. So that could be some sarcoma or some neurogenic tumor. Okay. So diagnose it. So anterior mediastinum already told you thymus, a thyroid, or a teratomas, etc. Hilum Waverley sign. A shell-out sign of the hila is called the Hilum Waverley sign, used to determine the localization of a lesion in the hilar region in the chest X-rays. If hilar vessels can clearly be seen inside the lesion is either anterior or posterior to the hilum. If the hilar vessels cannot be discriminated from the lesion is at the hilum. Useful for separation of a true hilar masses from superimposed pulmonary opacities. See here. See the picture. See the very big mass. Very big mass. This is only the heart. So just above the heart, this is aortic border. Okay. So PHS clearly depicts the hila. So this is which indicates that the mass is either anterior or posterior to the hila. In addition, the descending aorta is clearly seen. So this is the descending aorta, indicating that the mass is not within the posterior mediastinum. See the CT chest. Demonstrates an anterior mediastinal mass. The anterior junction line is obturated, whereas the lung interfaces with the hilar vessels and aorta are preserved. So retrocardiac opacities, DDs, left lower lobe collapse, esophageal diseases, posterior mediastinal tumors, paravertebral abscess, hiatus hernia, or aneurysm of the aorta. In aneurysm of the aorta, you can see the aortic line, para-aortic line. In the hiatus hernia, you see the paraspinal or azogus lines. The paravertebral abscess, paraspinal lines. Posterior mediastinal tumors, you see the behind the heart. So esophageal disease, again I told you. So left lower lobe collapse, you can find it. So these are all these can be seen by a good physician about all these DDs of your retrocardiac opacities. See here, the left lower lobe is reduced in the volume and the opaque. Frontal projection shows the double heart counter, orange arrows. In addition, there is a loss of the left hemidiaphragm and the descending aortic lines. See the aorta here, aortic knuckle. So you are not able to see the aortic lines here. See again a small arrow is here. So this should be the lung, the loss of this lung, left lower lobes, collapse. Now coming to the last parts of the lecture, diaphragm. Already told you right lung higher than the left lung, about 2.5 centimeters or 1 intercostal space. Diaphragm shape and contour, you know that concavity. Cardiophrenic and the costophrenic angles, they are very clear and the sharp. Gastric bubble and colonic air, gastric bubble on the left side. Subdiaphragmatic air is a pneumoperitoneum, it's an emergency one. See here the elevated hemidiaphragms. See which one is elevated here, right or left? So this is an abnormal. Usually expect right diaphragm is at higher level than the left hemidiaphragm. So what are the reasons? Maybe the phrenic nerve palsy or diaphragmatic herniation, eventration, abdominal tumors. See the effusion. Other switches to mimic an elevated hemidiaphragm. Here elevated hemidiaphragm. Here may be subpulmonic effusions, some diaphragmatic hernias, diaphragmatic rupture, tumor of the pleura of the diaphragm. See the continuous diaphragm sign. See the diaphragms here. See the right. So this is the left and there is a continuous. So there is a distance between heart border, lower inferior part of the heart and the diaphragm markings. Are you appreciating? So this is a continuous diaphragm. So this is a continuous diaphragm sign. So continuous lucidity outlining the base of the heart representing the pneumomediastinum. Air in the mediastinum tracks extrapleurally between the heart and the diaphragm. It can have a similar appearance but will show the air circumferentially outlining the heart. So these are the pulmonary vessels. See the left main pulmonary artery passes over the left main bronchus and it is higher than the right pulmonary artery which passes in front of the right main bronchus. So the right one, this is the left one. So these are the hidden areas. So there are some areas that need a special mention. So that is your epiphysis. These are your hilar, retrocardiac areas. This is the subdiaphragmatic areas. See the heart. See the left atrium. Here this is the left atrium. See the left atrial appendage. So in your mitral stenosis, severe mitral stenosis, so there will be the left atrial enlargement and there will be this concavity of this left border will be lost and you will have a convexity of the left border. See the right heart, right border of the heart is formed by the right atrium. Left ventricle. So this is the left border is formed by the left ventricle. This is the left ventricle. Situated to the left and the posteriorly. So this is the right ventricle. Most anterior structure. Most anterior structure is the right ventricle. And most posterior structure is the left atrium. So most posterior left atrium, most anterior right ventricle. See the cardiac shell out. See this is the aortic arch I discussed about you. This is the aortopulmonary window. Left pulmonary artery. This is the left pulmonary artery. This is the left atrium. So this concavity will be lost in the left atrial appendages or left atrial enlargements. This is the left ventricle. In massive left ventricular enlargement, this border will be like this. This is the descending aorta, right atrium. So the right border is formed by the right atrium. Right ventricle will be here, most anterior part. This is the right pulmonary artery, and this is the ascending aorta. So the ascending aorta, this is aortic knuckle, and the descending aorta, so like this. This is the left pulmonary artery, and this is the right pulmonary artery. See the constrictive pericarditis. See the thickening of your pericardium. See, you can beautifully appreciate here. Are you appreciating? Just like your aortic calcification. Most of the elderly individuals, if you take an X-ray, so the calcification of the aorta. The same way you can see here, this is a pericardium. So calcification of the pericardium, here constrictive pericarditis. See here, in the left lateral picture. See the cardiomegaly, flask-shaped heart, massive pericardial effusions. See egg on side. So the cardiomegaly. Here the left atrial enlargement and the left ventricular enlargement, maybe because of the MS and MR. See here, solitary pulmonary nodule. See the pulmonary artery here. So the left pulmonary trunk. Here the right pulmonary artery. Okay. So this is the ascending aorta. So this is the aorta. So the diaphragm. See the difference here. So structure here. So the right diaphragm is at lower level, left diaphragm is at a higher level, and there is some eventration of the diaphragm. So this is the diaphragm. You see the posture, gaseous distension of the stomach or the colon, dorsal scoliosis, pulmonary hypoplasia, pulmonary collapse, phrenic nerve palsy, eventuation, pneumonia or pleurisy, thromboembolism, rib fractures, subphrenic infection, subphrenic mass. See the right atrium enlargement. Because right heart border is formed by the right atrium. This is the right atrial enlargement. So this is the right ventricular enlargement going this way. Suppose the left ventricular enlargement. So this enlargement like this. See the left ventricular enlargement. Okay. Here the left atrial enlargement. So this is all I told you. A classic water bottle shape of a large effusion, pericardial effusion. So same thing here. Extras, soft tissues. See, I told you. See here the breast, no breast here. That is mastectomy. So all the female physicians. So please concentrate here. Okay. Right breast, left breast is lost. So the previous breast cancer of the left breast treated by the mastectomy. So this is the, see the difference here. So because of loss of the breast tissue, here you are able to see the lung tissue very clearly. Whereas on the right side, you are not able to see the lung appreciation here. So don't jump to put some diagnosis here, maybe pneumonitis or some consolidation or some abnormality here, because it is dark here, not that dark. Here some opacification is there. So this opacification is because of the breast tissue. Here no breast, so more lucency here. So increase the density over the right lung, decrease the density of the left lung. So what is the reason here? See in this picture, you can appreciate the breast shadow here. This is the breast shadow. Here, no breast shadow. See the rib fractures. See the surgical emphysema. See, this is all surgical emphysema. Can you appreciate hair here? Hair here. So this is the surgical emphysema. Okay. See in the neck also. Surgical emphysema. So these are all the surgical emphysema. Some fractures here. Okay. Maybe pneumothorax, maybe hemothorax, etc. Yes. The posterior, anterior, spinous processes. See the multiple fractures here. See one fracture here, one fracture here. Okay. So you can appreciate here. See here, fractures. See the masses here. So the mass doesn't mean a growth of the malignancy. Don't think that all the masses are because of the malignancies. So that is the most important take home point. So here a big mass is there, almost like a Pancoast tumor. Okay. See in this abnormality, there is again a big mass is here. So the take home messages, the chest X-ray is the most commonly performed and easily available modality of the imaging. Step-by-step approach. Always correlate clinically. That is very, very important. So don't take the history first. Examine the patient. Get a chest X-ray done. And then read according to the symptomatology and your clinical signs. So always correlate clinically. Don't miss the hidden areas. So especially in the apical areas, retrocardiac areas, or diaphragmatic areas, etc. So whenever you review a chest X-ray, always use a systematic approach. Inside out approach. First the cardiac counter is evaluated, followed by the mediastinum and the hilum, subsequently the lungs, lung borders, and finally the chest wall and the abdomen of the examined. You have to know the normal anatomy and variants. Find subtle abnormalities by using the shell out sign and the mediastinal lines. Once you see an abnormality, use a pattern approach combined with a clinical presentation and data to come up with the most likely diagnosis. Not only your diagnosis, you are not able to come to a reasonable diagnosis, at least you will be happy in our differential diagnosis. So thank you very much for your patient hearing. The practice of medicine that our historical ancestors could only dream of, and we have access to amazing the treatments and cures for our patients on a daily basis. Medicine really matured me as a person because a physician, you are obviously dealing with the life and death issues. If you can handle life and death issues, you can handle anything. So that is the reason I say that physician is the best person, best branch of all branches in medicine. Thank you very much.